sir?
Okay, we'll start. So welcome once again for the seminar Academic Activity from Hand to Shoulder Clinic. Let me introduce our participants. Today, Dr. Ankit Singh will be presenting on Kienbock's disease, advanced or late stage. What is the management, line of management? Dr. Ankit, welcome. Dr. Akram, welcome. Dr. Hiba, welcome to the meeting. So, Ankit, we can start now. I'll just share screen with you.
On the recent advance in the management of the advanced Kienbock disease. So just giving you the brief outline about the Kienbock disease, it is defined as the avascular necrosis of the lunate bone. It is frequently seen in the age group of 20 to 40 years of age with a young male preponderance. The etiopathogenesis has been associated with repetitive trauma, biomechanical factors such as ulnar negative variance, the anatomical factors such as variation in the lunate vascularity and increased intraosseous pressure. The clinical presentation predominantly involves a long-standing and a progressive pain over the dorsum of the wrist with a weak grip strength and the decrease in the flexion extension arc. The most common classification which has been used for the staging of the Kienbock disease is the Leishman classification, where the stage 1, the changes can be seen on MRI only. Leishman stage 2 shows lunate sclerosis. 3A involves the collapse of the lunate bone without any scaphoid rotation, whereas 3B involves the collapse of the lunate with fixed scaphoid rotation. And stage 4, the last stage, where the lunate collapse along with the scaphoid rotation and there is advanced arthritis, there is a degeneration of the adjacent intercarpal joints. A newer classification is by Bain and Begg, which is an arthroscopic classification, where, as you can see, there is a grade 0, where there is no non-functional surface. Grade 1 shows one non-functional surface, such as a proximal lunate, as seen in the diagram over here. Grade 2 has two subparts. 2A, there is two non-functional surfaces, such as a proximal lunate and the lunate facet of the radius. Grade 2B involves proximal and the distal lunate. Grade 3 involves three non-functional surfaces, where the capitated surface is the one which is only preserved, and both the poles of the lunate and the lunate facet of the radius is involved. And grade 4, all the four articular surfaces are non-functional. So this is a brief outline about the management of the Kienbock disease in general, where the stage 1 is usually managed by immobilization and NSAIDs. Stage 2 by various joint leveling procedures, radial wedge osteotomies, and core decompression and revasculation procedures. Stage 3 is managed likewise. The more important and a difficult stages to manage are the stage 3B and stage 4. Usually in advanced diseases like from stage 3 to 4, the LRTI, arthroplasty, or the arthrodesis, this salvage procedures were used. They have several limitations. For instance, in a proximal row carpectomy and in a partial carpal fusion, there is a decreased mobility. Arthroplasty has an issue of an instability, and LRTI is devoid of sufficient mechanical support. So today, we'll be dealing with this advanced surgical technique of using 3D printing assisted autologous costochondral transplantation. It was performed by Dr. Zhu Zhenzong at a Shanghai Medicine University at Shanghai. And this article was published in JBJs in December 22. So this was the case report where the patient was a 46-year-old young male with a right wrist pain and a gradually progressive loss of movement since 7 years. On examination, there was a limited flexion extension arc with extension involved more than flexion. And the left wrist was devoid of any asymmetry or deformity. It was completely normal. Various scores were recorded, such as VAS score, DASH score, and the modified Mayo wrist scores for comparison with the post-operative results. As you can see in the X-ray image, which has been attached here, you can see the sclerosis and the collapse of the lunate, and also there is an extensive arthritis in the wrist. There is also an MRI image on the right where T1 is showing an hypointense lesion of the lunate, and the T2 is showing a hyperintense lesion. Now the pre-operative planning was done and the CT scans of the chest and bilateral wrist were obtained. The sixth rib was chosen for transplantation after they have matched the length of the narrowest side of the intact lunate with each costal cartilage, and they determined that the narrowest matches with the sixth rib. The 3D data of the left lunate was then flipped vertically in order to match the lunate of the right side, which was the involved side. And the 3D prosthesis was created on a 3D printing machine. And the machine was Formlabs using an SG resin, again by Formlabs. The images can be seen on your right. As you can see in the bottom, they have taken a 3D data of the left lunate, they have flipped it and then they have printed it. The resin template can be seen. Further, they have sculpted the costochondral graft which they had harvested from the sixth rib and they had replaced it. As you can see in the image A, there is a transverse incision which they had taken over the sixth rib, and around a 2.5 centimeter rib osteochondral fragment was harvested. Now, the wrist surgery was started with the patient under tourniquet cover and the hand in pronation. And by following a usual dorsal approach, they have reached the lunate bone and they have excised it. Now, after the surgical site had been thoroughly irrigated, they have used a 3D printed HG prosthesis. They have inserted it and its suitability was tested. Now, a scalpel was used to sculpt the costochondral graft which had been taken from the rib, and they have shaped accordingly, matching to the 3D printed prosthesis. And also they have drilled a hole on the coronal aspect, and the palmaris longus tendon was harvested, and the drilled, it was passed through the scaphoid through the drilled hole on the coronal aspect of the lunate, and furthermore onto the triquetrum, as you can see in an image on the lower aspect. And in order to give a sufficient stability, they had sutured the palmaris tendon back with the remaining scapholunate and the lunotriquetral ligament. As seen in the 14-month follow-up, the patient had no pain with intact neurovascular status. The grip strength and the wrist movement was improved, as was seen in the VAS, DASH, and the modified Mayo wrist score. The image on the right-hand side, you can see the X-ray and MRI. So the X-ray, in comparison to the previous X-ray, the pre-op X-ray, the degenerative arthritis had regressed, whereas the MRI is showing that the graft is relatively well positioned and has not been absorbed or calcified. The novel surgical strategy, which combines 3D printing and the costochondral transplantation, it offers a therapeutic option in advanced Kienbock disease. The use of 3D printing, it ensures that the complex shape and structure of the carpal bone can be recreated, thus giving an anatomical recovery and a rapid functional recovery. Previously, the shaping was usually performed subjectively based on a pre-op CT scans. Also, the over-trimming could not be corrected. In this particular study, a 3D printing based on a mirror symmetry with a healthy wrist, it gives you an accurate template of which the costochondral graft can be sculpted in order to match the prosthesis. Also, the use of the graft with an intact cartilaginous surface, it enables the filling of the cavity and relatively good functional range of motion as demonstrated in the follow-up results. Also, another innovation was the technique of the fixation method. Usually, the lack of congruity and instability are limitations of the conventional lunate arthroplasty. Here, the repair of the scapholunate and the lunotriquetral ligaments after the prosthesis implantation is usually difficult, whereas here they have drilled the hole, they have passed the tendon through it, and after the passing of the tendon, they had pulled the graft into the cavity and they have sutured it back in order to give the stability. Thus, the palmaris longus tendon was used to give a high dorsal strength. Also, the drilled holes, they facilitated the flow of synovial fluid so that an adequate nutrient supply is maintained to prevent the graft degeneration. The challenges which was seen in this study was a precise 3D sculpting of the costal cartilage is required in order to replace the lunate, because it determines the reconstructed anatomical position and function. Also, the size of the costal cartilage presents individual anatomical differences. So whether it will match with each patient's lunate remains uncertain. Also, being a case report, the level of effort is relatively low, and a control studies with traditional surgical techniques was needed in order to ascertain its efficacy. A longer follow-up, more than 40 months, is needed in order to ascertain whether a resorption of the graft is being taken place or not. The way forward is this study is of novelty, but more such studies are required with a longer follow-up in the future so as to ascertain its efficacy in comparison with the traditional surgical techniques. Thank you so much.
Ankit, good presentation. But as we say, we have to, it's a everything printed, we had to, everything printed in literature or published in literature, we have to assess it um, critically, then only we can look forward to adapt. So one thing is that people have tried this like pyrocarbon lunate prosthesis, which was there with extension maybe 15 years ago, had a same principle of hole in which tendon used to do the fixation. So fixation part is not a novel. It has been tried, but with a metallic or you can say artificial processes. In extension, it was a pyrocarbon because pyrocarbon has a very good you can say longevity and multiple cycles. The wear is very low in pyrocarbon. We have also done a study on that. Second thing is when wrist is collapsed, it was an advanced collapse.
Yeah.
So how difficult is it? Does author talks about it to put a normal size unit? Because you have to distract a joint to put a normal size unit because it is a very slow collapse, and so ligaments etc. they become tight. So we have to look at that part also. Plus, we are not changing the pathology. See, earlier lunate was avascular. This cartilage is also avascular. So we don't know. Will we get such a thick cartilage? Will it get a nutrition by diffusion only, or will it require something? So this is something we have to really look forward for longer follow, and more studies are required. Other thing which we can maybe thinking about it, 3D printed metallic ones, prostheses, using the same study and making a hole in that and fixation, that can be tried. Other thing is now with the robotic things, you can sculpt matching cartilage by using a burr. So these things, these technologies are available, but we have not discussed about other things like fusion and other things. What are the results and whether they're comparable with the replacement? Because replacement in the wrist, we are trying for a long time. Everyone around the world is trying, but not a lot of successful because of very complex biomechanics. So I think we have to look at this study more, watch it very carefully before we adapt this to our practice. Akram, any?
Yes, few insights that, okay, the biggest question is the vascularity of this graft.
Yeah.
B, technical difficulty in sculpting it. I mean, you are still doing an eyeball sculpting. You are actually seeing it and then sculpting. There is no die kind of thing which will make sure that the facets are sculpted accurately. Biggest problem would be vascularity. The cartilage will draw its nutrition through diffusion, which the parent, the native unit, failed to do. So how do we expect this? I mean, we need a larger number of patients.
To sustain.
Yeah. B, they mentioned that there is regression of osteoarthritis, which is difficult to accept. I mean, did they quantify the degree of arthritis? Did they do any what was the level of arthritis between radiocarpal joint, whether it was midcarpal arthritis only?
Post-op MRI, cartilage thickness on the radius side or something like that.
Yeah.
Would have been more.
I mean, one result may be good, but
it is irregular still in MRI. Distal radius is still irregular. Yeah, it is something which is good, very novel, and we must appreciate the hard work. But again, to reproduce, see, in science, you should be able to reproduce the procedure, reproduce the results. So more people have to do this to reproduce the result. The guy who designs the surgery, maybe because he has all the concept and everything, if surgery is not reproducible, then surgery doesn't last long. Dr. Heba, you want to say anything? Yeah, Ankit.
Sir, I would like to put forth the question. I would really like to know from seniors that what was the difficulty which was seen, as you had mentioned that pyrocarbon was used earlier, even a semi-constrained metal arthroplasty was done, I think quite a few years back. So what was the problem then, so that, we are going ahead with such type of surgical techniques?
Loosening the prosthesis doesn't last long because of so complex biomechanics. The scaphoid has to rotate, lunate has to rotate, the rectotum has to rotate. So that palmaris longus will give away after some time, or any artificial material will give away after some time. Even people have used a floating prosthesis. Floating prosthesis is because there is no attachment. There's no attachment, so there is no loosening, but it causes more arthritis, more of wear and tear. So all these things have tried, but cartilage thing is definitely it's a good idea. But again, 3D printing is not being used to the fullest. If you could attach a robotic burr with the 3D printing, which can accurately sculpt the cartilage. Very accurately, they can sculpt the cartilage, sub-millimeter accuracy. Akram, you want to add anything?
That's it. I mean, that is a very pertinent question. So the 3D printing.
Other thing which I would like, it is collapsed. How to get the real size lunate inside in a collapsed wrist? It is difficult. Maybe they're using distractor, or on the table, was there any distractor used, or
nothing was mentioned in the article?
Just a traction is good enough, intra-operative traction, manual traction.
Sir, will there be, in cases of advanced collapse, where it will be difficult to put the graft accurately inside the cavity, so will there be any logic of a staged surgery so that the first stage will give you gradual distraction in order to create an
space? Again, whatever we are discussing will be more theoretical. We don't have any experience, but what we are talking is only logical. But anything logical will work. It's not true. That's what biology is about. Biology and physics, that's how they're different. In physics, logic works. Biology, it doesn't work.
One more question, sir. How long should a patient be followed up in such a similar case in order to assess?
At least 2 years. People say at least 2 years.
That the graft has not been resolved, or it's not been calcified.
See, at least 2 years is the time, but we used to give for any publication. I don't know, because there's a pressure for publication nowadays because you want to be first. But when we were students, it was a dictum that less than 2 years follow-up it's not like something easily accepted for publication.
So, Akram, you have anything? Do they have any plain X-rays post the surgery?
Immediate post surgery, there is no X-ray, sir.
No, this is the post surgery X-ray. What is showing C that
this X-ray is of around 14-month follow-up, sir.
Yeah.
So what they have done,
So on PA view, I don't see I still see a gap between lunate and radial fossa, but I don't see the graft actually. I mean, either it has.
This is complete cartilaginous. There is no bone in it.
Yeah.
It's a complete cartilaginous graft. That's why the signal intensity in MRI also different.
But the capitate looks close to the. It looks diving into the lunate fossa. If they have restored the height, if they have restored
that's what I'm saying. Maybe that is one of the biggest question. To restore the height, you're putting excessive pressure on the graft.
Sure.
So
yeah, one case with such less follow-up can. But yes, I mean there's always a new way to think about it. But Dr. Vikas is very right that the 3D printing technology has not been used to its fullest strength. I mean, it could have been more accurate. I mean, 3D, you have in your hand a resin printed lunate, but we can't copy that on a cartilage. I mean, unless there is a robotic thing bar which is actually matching the cuts.
Okay. So Hiba, you want to say anything?
Is she there?
Yes, she is there, but okay. Yeah.
I'm here. So, for me, actually, the question is, it is advanced wrist arthritis, so I can't understand how they can do something to reduce the arthritis. So, answer all that already.
Okay. So, Ankit, when you're reviewing literature, what were you finding? Because nowadays the drilling or decompression, co-decompression is becoming very popular in our country. How well it is supported by literature?
Sir, when I was going through the literature regarding and when I chose this particular topic, because all the other topics were related to the limited carpal fusion, and the core decompression was more in 3A, and a very few articles I've seen that they have used in stage 3B or stage 4 for that matter.
Okay.
Yes. Other articles which I found was there was a.
So you want to say 3B, the core decompression is not really indicated as per literature?
I didn't find much of stage 3B and stage 4 for core decompression. It was more up to stage 3A.
Okay.
Whereas on the other hand, I could really find a long-term follow-up of scaphocapitate arthrodesis with lunate excision, almost a 7-year follow-up. And there is also a paper where they have seen the influence of a carpal ulnar translation on clinical outcomes after scaphocapitate arthrodesis in a treatment of late-stage Kienbock disease. So this article has been published in the Journal of Plastic and Reconstructive Surgery by Dr. M.D. Park from Korea. And it was in January 2022. And I would just like to briefly say the conclusion of the same, that they had suggested that sufficient pain relief and functional improvement is achieved after scaphocapitate arthrodesis in a 7-year follow-up for the treatment of stage 3B and stage 4 Kienbock disease. And it disregards the occurrence of carpal ulnar translation. And the only patients where overcorrection of a radioscaphoid angle less than 30 degree, it induced more of a carpal ulnar translation. Anything above 30 degree, they didn't find any significant ulnar carpal translation after scaphocapitate arthrodesis.
Just because it starts impinging on the radial styloid, the scaphoid starts impinging. So, Akram, you want to add anything so that otherwise we'll call it a day? So, Ankit, thank you very much. It was a really nice presentation. And I think we'll think about it. Let's see, look for literature, what to do. Oh, yeah, Akram, you want to say anything?
No, I just wanted to add, there is a scope of denervation of the wrist in painful wrist. I mean, people are doing denervation very routinely, particularly in China and in South Korea.
Denervation is West also was very commonly done. Only thing is after 2 years, the pain starts recurring. It's not, denervation is not permanent. Somehow nerves regenerate or things like that. So denervation, especially in the wrist, doesn't last lifelong. That is the issue. Like maybe
Sure,
next time, Ankit, we talk about denervation.
Sure, sir.
Okay. Okay. Thank you very much, Ankit. We had a
Thank you so much,
very
sir.
good presentation. It was really eye-opener, using technology, using new things. And I think we'll try to adapt or maybe make it better if it works, or we'll keep a close watch on this technique. Thank you very much.
Thank you,
Thank
sir.
you.
Thank you
Thank
very
you.
much.